All right, so we have a long one here. I'll try to get through it as quick as I can. We're going to be talking about feeding, eating, and elimination disorders. Okay, so the first disorder we're going to be discussing is pica. Now, pica is when an individual has an appetite for largely items that are non-nutritious. So this can include ice, hair. It could even include things like metal or stones. So just anything that's non-nutritious in nature that one would not normally consider part of their normal diet. Now, diagnostic criteria, mostly all you got to focus on is the persistence of time. Pica must persist for at least 1 month before it can be diagnosed, and it can't be in the presence of other developmental disorders. And of course, it must affect their ADLs. The next disorder is going to be rumination disorder. Now, this disorder is when an individual will ingest food but will immediately regurgitate the food. Now, this regurgitated food can either be spit out or, more gross, it could be re-chewed or re-swallowed. So a way to remember this, I think of rum. So rumination rum. Rum is normally regurgitated if you drink too much, so that's a way to remember rumination disorder. And similarly to pica, it must also be present for at least 1 month to be considered diagnostic. Okay, so next we have avoidant restrictive food intake disorder. Now, this disorder is similar to anorexia in that it requires or that it entails a decrease in food intake, but in contrast to anorexia, avoidant restrictive food intake disorder, there is no associated distress or conflict regarding the person's body shape or any fear of fatness, whereas these concerns are prominent in anorexia. We're now going to move on to elimination disorders. These disorders are unique in that they are typically first diagnosed in childhood or adolescence. The first elimination disorder is going to be enuresis. Now, don't get confused with enuresis and onchoparesis, which we'll be talking about next. Enuresis refers to urine. So enuresis has the word urine in it, or uresis, which refers to urine. So this is a disorder where there's repeated voiding of urine into either bedding or clothes. And this can be either involuntary or voluntary. Now, diagnostic criteria for this, it must occur a minimum of 2 times a week for at least 3 consecutive months or cause significant distress in the child. So it doesn't have a true time period as long as it causes significant distress, so keep that in mind. Also, of course, the child has to be old enough to signify that actually voiding himself is abnormal, because the child needs to be potty trained. So that minimum age is going to be 5 years old. So just keep an eye on the minimum occurrence number. It's 2 times a week for enuresis, but as you'll see shortly, onchoparesis is only required for 1 time a week. So although this is you're going number 1, it requires 2 times a week. Now we're moving on to onchoparesis. Now, onchoparesis, as we stated previously, is related to the feces. So onchouresis is urine, onchoparesis is feces. And this can also be involuntary or voluntary, in contrast to onchouresis, which is 2 times a month. Onchoparesis is 1 time a month. So for going number 2, it's 1 times a month, and for going number 1, it's 2 times a month. So they're opposite. Now, for this age, since it's probably harder to control your urine than controlling your poop, the minimum age of diagnosis is 4 years. So they must be at least 4 years, 4 years old before this disorder can be diagnosed. Now, the most common cause of onchoparesis is going to be chronic constipation. So what happens is the child becomes constipated and they get a big, basically a poop plug, as you see in this picture. And what happens is over time, fluid and other types of feces will kind of leak through. So that leakage is what is characterized as onchoparesis. So the treatment would be to basically clear out that constipated rectum. Next up is eating disorders. These disorders include anorexia nervosa, bulimia nervosa, as well as binge eating disorder. The first eating disorder is going to be bariophobia. So bariatric refers to an obese individual. So this is a phobia of bariatrics. So bariophobia, which is the fear of becoming heavy. When this occurs in children, they are typically given a low-fat and restrictive diet in hopes of fighting off obesity or heart disease. However, because the child is still growing, this has an effect on their growth pattern as well as their overall development. Whereas in adults, this is a self-imposed condition that results in a restrictive diet. Unfortunately, there is a lack of appropriate nutrition in these patients. So eating disorders are, as we know, most common in women, most common in white women, especially those living in an industrialized society, of course, because there's more access to food. Now, social factors can lead to these eating disorders as well. Interestingly, anorexia is not associated with a conflictual family, so they have more normal families, whereas bulimia does have some kind of family conflict in their past. So the way to remember this, I think of families are bullies. So bulimia results in bullies and families, so that's the one that has conflict. So there is a tool that is used by patients to self-report eating disorders, and it's called the Eating Attitude Test. So a patient will take this 26-item test and can dictate with a pretty reasonable accuracy of 90% whether or not these patients do have an eating disorder or not. Okay, so we talked about bariophobia. Now the first major condition or eating disorder we're going to be discussing is anorexia nervosa. So this disorder, which the term anorexia actually means a lack of appetite. However, this is not normally the case. Patients typically have a large appetite because they're constantly in a starving state. So the most common and most obvious symptom associated with anorexia nervosa is a refusal to maintain a normal body weight. So these individuals are significantly underweight. However, even though they are underweight, they still have an intense fear of becoming fat. And they don't realize that there is a problem. So they are egosyntonic. They are in contrast to bulimia, which is ego-dystonic. They realize that there is a problem. However, those individuals continue to do the actions. Whereas in anorexia, they're doing it because they fear that they're going to become fat. So they are egosyntonic. Now, when it comes to prevalence, of course, anorexia is more common amongst females than males, and is actually a pretty high ratio of 10 to 1. Now, when it comes to mortality, the majority of the deaths associated with anorexia are going to be caused by heart failure and arrhythmias, and we're going to get into some of those reasons here in a few minutes. Now, as you probably should know by now, the two types of anorexia nervosa are going to be restricting type, as well as the binge eating and purging type. So the psychological features of anorexia nervosa are did what you would expect, right? Perfectionism, feeling of ineffectiveness, inflexible thinking. Remember, they're egosyntonic, so that's inflexible. A lot of these you can kind of reason your way through, so I won't belabor the point any further. Now, there are many kind of co-psychiatric conditions that will present along with anorexia nervosa, most commonly being dysthymia. Now, remember, dysthymia is a more modest depression, but it is more long-term. And I mean, I don't know about you, but if I was eating as little as them, I'd be depressed too. I like food. And there is also an association with OCD, obsessive compulsive, and this may also be exacerbated by the malnutrition that occurs in these patients. The profile of anorexia nervosa is pretty obvious. They have food rituals. They have prolonged exercise. Obviously, they have a preoccupation with food. And they are typically hungry, obviously, because they're not eating, but they refuse to eat. So the three criteria for diagnosing anorexia nervosa are going to be, number one, a low body weight. Number two, they're going to have an intense fear of gaining weight or becoming fat. And number three, They will have a distorted perception of body weight and shape. So these individuals will think they're much larger than they truly are. So there is no official cutoff for the weight or BMI that is considered anorexia nervosa. However, they use a rough guideline of around 18.5 and under is when you start to get into the realm of anorexia nervosa. And it will decrease there from mild, moderate to severe. Severe will be extreme is a BMI less than 15. So it starts at 18.5 and it becomes extreme when the BMI is less than 15. So this is a good picture to come back and reference later, or I guess later tonight, because we're not looking at this later. But it is good to look at, and you could probably work your way through a lot of these presentations if you see them on a multiple choice, for example. So the pathophysiology of a lot of these can be associated with really two key mechanisms. Well, really, it's the lack of eating, so you're going to have low nutrients. So specifically in this section, you're going to have low glucose and low fats. So with regards to amenorrhea, first to review, if you remember, amenorrhea is characterized by an absence of at least 3 consecutive menstrual cycles. So that's when it's caused amenorrhea. And this is due to a dysregulation when it comes to the sex hormones that normally stimulate the menstrual cycle. And if you remember, sex hormones are fat soluble. So if you're in a low fat state, in my mind, that is what causes this dysregulation because there's less fat and it's just going to kind of mess with the hormones. Thus, you're going to have amenorrhea. Now, when it comes to chelosis, I think of that from iron deficiency anemia, and these individuals are also anemic, so I believe that would be the cause of the chelosis. Postural hypotension, dehydration, or edema. These are all due to, well, for the edema, you have low salt. When you have low salt, you're going to be dehydrated. Remember, fluid follows salt. So low salt, you're going to be dehydrated. You have that less osmotic pressure, so you're going to have edema. And this also coincides with the postural hypotension because your volume depleted. Additionally, the heart is going to slow down because it's going to try to kind of compensate for that lower metabolic state because you have less glucose. Your body's not going to want to use as much energy as normal. So you're going to be bradycardic. The hypothermia occurs due to the dehydrated state and the hypotension because when there's less fluid, less blood is what makes that temperature. So that's going to lead to the hypothermia. Now, when it comes to the role of osteopenia and anorexia, the name of this game is going to be mostly calcium regulation. So you're going to have a reduced mineral density, mostly due to decreased calcium. And there are multiple different factors here that can lead to this. So for one, you're going to have malnutrition, so you're going to be taking in less calcium. Additionally, you're going to have that dysregulated of that sex hormones, particularly estrogen in this case. Estrogen and glucocorticoids both directly and indirectly play a role in absorbing calcium or making it less reuptake. So that's going to also lead to less bone density and osteopenia in these patients. Now, furthermore, like we said, we're going to have a hypothermic state. So you're going to have a low body temperature. This is due to that low metabolic process that's going on in these conditions. So you're going to have a low thyroid hormone, as well as some signs of GI dysfunction like constipation, which makes sense because if you have less fluid in the body, you're going to have less ability to kind of have that more normal bowel movements. Additionally, you're going to have that bone marrow hypoplasia, which will lead to leukopenia, anemia, as well as thrombocytopenia. Now, probably the most dangerous of the side effects that is associated with anorexia is going to be the cardiovascular related side effects. So once again, you're going to have a slower metabolic rate, so you're going to have a slower heart rate, which is going to indirectly lead to a decrease in blood pressure. You're also going to have a decrease in heart mass because remember the heart is a muscle, and this can lead to cardiomyopathy and consequentially can have a role in causing a mitral valve prolapse. And the prolapse can also be associated with hypovolemia as well. Now, probably the most dangerous acutely is going to be the electrolyte imbalance, and this is associated with heart failure as well as sudden cardiac death. And this can be caused largely by a decrease in potassium. So you're going to be hypokalemic, and this is partially due to a lower intake, or also just mostly the vomiting or the diuretics that can be taken in these individuals that do that binge and purge type of anorexia. Lastly, you have refeeding syndrome. So what happens in refeeding syndrome is when an individual who has been starving eats too much too rapidly, the body reacts to the nutrients that they're intaking by having to break those nutrients down. However, to do this, you must utilize the stores of the like the phosphorus, the potassium, and all those other electrolytes that were already low to begin with. They will become even lower acutely, which can lead to dangerous and possibly deadly side effects in these patients. And lastly, these patients will also have some iron deficiency anemia, of course. They're more prone to infections, and they may also see some other abnormal kind of physical characteristics, and not 100% sure, but I think these are related to the dysregulation in the sex hormone. So things like hirsutism, alopecia, yellowing of the skin, as well as lanugo. Okay, so we're going to move on to bulimia. Now, bulimia, like anorexia, encompasses many episodes of binge eating followed by inappropriate purging. So it sounds like one of the two types of anorexia. However, the major difference is that in bulimia, these individuals have a normal weight, or they may actually be overweight. We're going to get into these reasons here in a few. So bulimia is most common in women, typically in their early 20s. And once again, these individuals are typically either overweight or within normal weight. So these individuals look quite different than those with anorexia. So this is also associated with many other co-psychiatric problems similar to anorexia. So they kind of go hand in hand. So this is a good illustration showing the cycle that occurs with individuals with bulimia. So these individuals will have a bad day, they'll feel depressed, they'll feel anxious, so then they binge eat. Now after they're done eating, they're like, oh crap, I don't want to get fat, so then they purge. After they're done purging, after time goes by, they're no longer scared of getting fat, and then they start to feel guilt. And then basically the cycle continues. So that guilt can lead to depression or anxiety, and then they binge and so forth. So you kind of put that together. Now, diagnosis of bulimia can occur under 3 criteria. So first, binge eating needs to be present. Secondly, there needs to be an inappropriate compensatory behavior. So this can be purging or non-purging. The non-purging kind of consists of like a reactory dieting phase, a fasting phase, or more commonly like excessive exercise, diet pills. That can be the non-purging type. And then thirdly, this needs to occur at least once a week for at least 3 months. So why do these individuals binge in the first place? Well, typically it's going to be caused by stress. So they eat to relieve stress. Remember that circle we talked about earlier, that anxiety or that stress leads to the binge eating. And it's important to note that the food that they decide to eat aren't typically the healthiest foods. They're not going out and binging on fruits and vegetables. It's going to be things like high carbs, high fats, just not very healthy. So when it comes to purging, there's 3 mechanisms: poop, pee, and vomit. So when it comes to the poop, you're going to have laxatives and enemas. Now these work in the large intestines. However, the majority of the body's calories that are ingested, that absorption occurs in the small intestine. So what happens is these individuals think they're losing all the calories that they ingested, but that's not actually occurring because the laxatives are working too far down in the tube. So overall, they start gaining those calories still, so they're still overweight. Additionally, that can lead to damage to the large intestine over the long term, which can lead to some chronic constipation. Now, when it comes to method 2, which is vomiting, there's 2 methods. There's fingers down the throat, and there's a syrup ipecac. And those have their own negative side effects themselves. So the fingers little less serious, you have some damaged knuckles, which is referred to as Russell's sign. And then you have the syrup of ipecac, which, if taken repeatedly, can lead to, it basically acts as a poison to the body. And that can lead to poison of all the major organs that filter blood or circulate blood, including the heart, the liver, and the kidneys. And just note that vomiting is the most common form of compensatory behavior in individuals with bulimia. Now, the third method is going to be through the urine or uresis, and that is utilized via diuretics. So diuretics function by helping you urese or lose water through the urine. But what happens is these individuals retain all the fat, so they're still gaining weight, and they also lose a lot of the electrolytes. So they specifically, or most importantly, is going to be the hypokalemia that can develop. Remember, most of the major diuretics, particularly the thiazides and the loop diuretics, those are, you lose potassium in the urine. So maybe the only exception would be the spironolactone, but those aren't the most commonly used. So you're worried about the hypokalemia specifically in these patients due to the cardiac arrhythmias that can occur in the future. Now, the medical complications that can occur in self-induced vomiting are going to be the scarring on the dorsum of the hand that is referred to as Russell's sign. There's also the potential of some enlargement of the salivary glands, as well as a rare but potential case of a ruptured esophagus. There's also the potential for eroding teeth in the enamel specifically. Some more complications associated with vomiting are going to be, of course, dehydration. You're going to have that alkalosis because you are losing that hydrochloric acid in the vomit. So you're losing that acid, which leads to the metabolic alkalosis. And if you remember, a metabolic alkalosis pushes potassium into the cell. So you're going to have more potassium in the cell, which is going to mean less potassium in the serum, which is going to lead to hypokalemia. You're also going to have some resultant esophageal damage, so you could have some sore throat, esophagitis, maybe some blood tinge in the vomit, so hematemesis. And also with the chronic vomiting, you're going to have that Mallory-Weiss syndrome. Additionally, with that repeated vomiting, that could maybe lead to some subconjunctival hemorrhage just from the chronic vomiting motion. Now, with the laxative abuse, you're looking at continued dehydration and resultant increase in aldosterone and vasopressin. Remember, those are released when the blood pressure begins to decrease. So you're going to have chronic elevation of the aldosterone and vasopressin. And then, of course, with the chronic defecation is going to lead to some rectal bleeding, similarly as you would see with the Mallory-Weiss type symptoms. And of course, when you're using the bathroom so much, you're going to have some abdominal discomfort. Remember also, you're going to be worried about myocardial damage, specifically from the electrolyte imbalance, hypokalemia, particularly with the diuretics, and then that potential for the myocardial damage due to repeated syrup of ipecac use. Remember that second type of bulimia nervosa, the non-purging type, that can be characterized by increased exercise use, and that increase or excessive exercise can be termed hypergymnasia. So gymnasium, hypergymnasia, that would be associated with the non-purging type of bulimia nervosa. Now we're moving into binge eating disorder. Now, binge eating disorder differs from the previous two eating disorders that we discussed in that there are no compensatory purging behaviors. So these are just individuals that, they just eat a lot, but they don't go through that additional purging step. Now, this disorder is more associated with obesity rather than decreased weight, as we saw previously. This one, the individuals are going to be more likely obese, and they're not concerned at all with their body shape. These people just simply, they love their food. Now, to diagnose binge eating disorder, the individual must partake in excessive consumption of food that occurs over a 2-hour period, and this individual is going to be consuming more food than the average person. There's also needs to be associated with 3 or more of the following symptoms. I'm not going to kind of discuss these, but mostly just, eating fast, eating alone, whatever. Thirdly, they need to be actually going to have some distress about the binge eating, so they are egodystonic. The frequency needs to occur at least once a week for 3 months, and the binge eating is not associated with either anorexia or bulimia nervosa. So the characteristics of binge eating itself is essentially these individuals will isolate themselves and eat a large quantity of food, typically junk food. And this binge eating is going to be triggered by a variety of different stimulus, similar to how it was in bulimia. These individuals become stressed, they become anxious, depressed, and that leads to them eating more food than they should. And they utilize this to kind of help with those stressful impulses. Now moving into nutrition, there's going to be a lot of numbers and a lot of memorizing that I'm not going to go through the process of learning myself, so we should be able to get through this section pretty quickly here. So when you're assessing an individual's diet, you're going to be comparing their calories intaken from a reference range. So this reference range is going to be called the DRI, or the Dietary Reference Intake. And this will have a list of the recommended dietary intake for the patient itself. Now, individuals with anorexia nervosa typically have a decreased caloric intake, typically less than 1,000 kilocalories per day. They also tend to avoid fat and likely will follow a vegetarian or a vegan lifestyle. So it is important to note whether that change of diet coincided with the onset of disease, because potentially you can fix the problem by just helping educate them the best way to intake proper nutrients. So these individuals may also have some kind of ritualistics or patterns when it comes to their eating. For example, they may space their meals out over a certain period of time. However, they do differ in a specific manner. For example, those with bulimia nervosa, they may eat quickly. So essentially, bulimia, you eat more and you eat faster. Anorexia, you eat less and you eat slower. I think that's a good way of putting it. So remember, when you starve yourself, you're going to be losing sugar and you're going to be losing fat before you lose any of your protein. So typically, these individuals with food disorders or eating disorders will have lower visceral proteins such as albumin or transferrin. However, they will have decrease of the sugar and fats, so low glucose, and they'll also have a low T3. Remember, T3 is a fat-soluble hormone, so it likes fat, so it's going to be low when there is a low intake of fat. Also note that the lipid panel may be abnormal, so they may have such as an elevated cholesterol, for example. However, this can be due to other circumstances besides the diet, such as hepatic dysfunction or hypothalamic dysfunction. So you need to don't immediately rush to change their dietary intake. Reassess these individuals after you address the other abnormalities within their nutrition. Another common abnormality is going to be hyperkeratonemia. So this can be caused by two circumstances. One is increased vegetable intake can lead to this, as well as a decrease in the inability to metabolize the keratin. This is because the normal metabolizers require certain nutrients that are typically decreased in individuals with anorexia. So there are certain metabolic changes that occur in anorexia nervosa particularly. So in anorexia, you can have low metabolic rates, specifically referring to the resting energy expenditure. This is the amount of energy that you expend while your body is at rest. So these individuals typically have a lower percentage than what is expected. And this is important when you are reintroducing nutrients in these individuals. So they may acquire a higher caloric intake during nutritional rehab. This is just something for the nutritionist to be aware of. But I would just be aware of the terminology of the resting energy expenditure, and just note that it is decreased in anorexia. Remember that this is different than in bulimia. Bulimia may have kind of unpredictable metabolic rate. I think this has a lot to do with just the fact that these individuals still absorb a lot of nutrients. This is more of a different kind of problem than anorexia. So referring specifically to anorexia right now, remember there is a abnormality when it comes to fluid and metabolic balance and rate. So with regards to fluid, you're going to have polyuria, and this is due to starvation. So that polyuria likely contributes to a hyponatremic state because water follows sodium, so you're losing a lot of sodium. When you lose a lot of sodium, you're going to start losing that osmotic pressure, so you're going to start having edema that's going to be in those third spacings. So you're going to have that edema potentially in the legs or in the pelvic region. And we just kind of talked about the resting energy expenditure in the last slide. So when it comes to examining weight, there are various methods. For example, there are growth tables that can go up to age 18. I'm sure those have their own pros and cons. You're also going to be wanting to weigh these individuals daily in the hospital or weekly in an outpatient setting. Just note that if you are going to be doing this in an outpatient setting, you're going to want to have them void in urine prior to checking their weight, or you're going to do an exam to determine if the bladder is full. All right, so we're almost done. We're moving into the treatment now. So treating eating disorders can be difficult and will require some work between multiple different specialties. So when treating anorexia, you're going to want to increase their weight and correct any malnutrition these individuals have. Remember, when it comes to anorexia, these individuals are significantly underweight, less than 18.5 BMI, whereas in bulimia, they can be normal weight or be obese. So just remember that difference. So in anorexia, you're correcting their weight, fixing their nutritional deficits, you're going to normalize their eating patterns. When it comes to bulimia, you're not caring so much about their weight in the short term. Even if they're overweight, you're going to leave them as is, but you are going to correct those eating habits initially, and then later down the road, you can worry about their weight. Referring to anorexia, the nutritional care can be much more of a challenge than compared to bulimia. These individuals often will require some form of hospitalization to begin their refeeding. This is because they require tight monitoring of their energy intake, and their intake must be increased gradually while minimizing the caloric expenditure because you want to avoid that refeeding syndrome. So the ultimate goal is to increase energy intake while also increasing weight gain. So the goal when it comes to anorexia is to increase their weight for about 2 to 3 pounds per week. So that's not a lot of weight. So you're doing this slowly over time. So about 2 to 3 pounds per week in hospital and about 1 pound per week in outpatient. So this is going to be a long and grueling process. So this is a pretty important topic here. So this refeeding syndrome. This is what happens when you feed someone who is starved or malnourished over a prolonged period of time too rapidly. So of note here, we're referring to phosphate. However, this also applies to potassium and magnesium. So what happens is these individuals are in a chronic state of depletion when it comes to phosphate, potassium, and magnesium. So when they are fed too rapidly, their body intakes a large amount of carbohydrate. That carbohydrate is broken down into glucose, which releases insulin. The insulin is released to try to metabolize the glucose. But when the insulin is released, that also causes the cells to reuptake phosphate, potassium, and magnesium. So essentially that low serum concentration of phosphate, potassium, and magnesium that was already low becomes even lower in these individuals. This can lead to tissue hypoxia, heart dysfunction, respiratory failure, and this is due to the diaphragm being unable to contract, as well as seizures. So that's why it's very important and critical that we are monitoring these individuals and feeding them slowly over a multiple long period of time. You don't want to overdo it too quickly. So if you see that these individuals are not gaining weight as expected, you should always check to make sure they actually are eating the food. And once they are at their goal weight gain, maintenance should be established at around 40 to 60 kilocalories per kilo, and that should promote proper weight maintenance as well as continued growth and development, particularly in adolescents. So this is referring to the proper amount of nutrients that you should be eating, particularly the macronutrients. So just note that carbohydrates should be the majority of what you're intaking, so about half, and the rest can be split between fats and proteins. So note, what are you losing first? You're losing carbohydrates first, so that should be the most that you retake. And then after carbohydrates, you lose fats and then proteins. So if you're going to require to supplement, highest amount of carbohydrates followed by fats and then proteins. Also important to note that when you are refeeding these individuals to try to gain weight, you're in an anabolic state, which means you're growing. So you're going to require about 100% of your recommended daily allowance of vitamins in order to continue to grow. And the same percentage of macronutrients also applies to bulimia as it did in anorexia. So after you address the nutritional deficits, you can treat these individuals with various psychological and psychotherapy options. So remember, the fear of gaining weight presents the greatest challenge in providing treatment to these patients. So you can address with individual therapy and family therapy. There is some evidence that states that family therapy is more effective than individual therapy. There is also an option of pharmacotherapy. However, this is only really effective in treating the co-occurring psychopathology such as anxiety and depression. They don't really work directly on the anorexia. They kind of just supplement the process. The treatment of bulimia can be considered probably a little easier than anorexia. You're going to be focusing on cognitive behavioral therapy as well as interpersonal therapy in these patients. Of course, if these individuals are depressed, which they often are, antidepressant medications are indicated in all three of the eating disorders discussed: anorexia, bulimia, and binge eating. Just remember that medication alone is not ideal for treating these patients. Psychotherapy is an important part and component in the treatment of these patients. Now, the prognosis of these eating disorders aren't the worst. However, there is a high relapse rate after treatment, so it is important to continually monitor these patients. All right, that's it. I think that's my final psychiatry video. I'm pretty excited about that. I hope it wasn't terrible, and good luck tomorrow.